but thank you so much for being there on time. Apologies that we are running a little late, so you had to wait a little bit. Uh, you know what? Siddharth and I we caught up for a conversation a couple of months ago, and we started, the conversation somehow moved to a point that patient aata hai from tier 2, they come to the city, they come to a metropolitan city, they go to a hospital, they get treated, they get operated, and then they go back to their hometown, and they ultimately need some local practitioner who they get under the care of. About who's going to be benefiting or the lifetime value of that of that patient, but it's about how does he or she get proper care. The continuity of care, that is a very, very important aspect that gets compromised unless this is addressed. And today, we have technology that is coming in, which is not only bridging the gap between these major cities as well as the tier 2, tier 3, but I think it is trying to build a network of doctors who can connect with each other and provide proper care to the patient. So that's the context of the conversation today. My first question would have been to Dr. Kler, but we'll reserve that question until he arrives. Sidharth, when we were discussing, we came upon this term called the loss of follow-ups. What does this term mean? Can you explain to us?
So essentially, loss to follow-up is very simply the number of percentage of patients who come back to the institute or the doctor where they initially sought care, right? So the denominator is the total number of patients and the numerator is the number of patients who come back. Let's take something like a therapy like cardiology. So if someone's had an angioplasty, loss to follow-up at the end of 14 days is typically about 10%, right? So there are 10%, 10 to 14% of patients who don't even come back for the first follow-up. But at the 3-month and at the 6-month stage, this number becomes fairly acute. So at the 6-month stage, in fact, it crosses 50%. So 1 in 2 patients does not come back for follow-up. The implications of this can be pretty severe. A lot of patients tend to be comorbid. If you take again an example of cardiology, you have a cardiologist choosing to operate on one of the coronary arteries which is blocked, which is completely blocked. But there could be other arteries which have a partial blockage, which needed to be medically managed. Otherwise, that would have also led, to somewhat more severe consequences. And the fact that the patient doesn't follow up because he's lulled into a false sense of complacency means that there could be risks in the future. So I think that's the term loss to follow up. And there are multiple reasons for this. Some of it comes down to sort of convenience or inertia, which is the patient feeling everything feels fine. Why do I need to go back? There is obviously economics. More than 50% of patients, their procedures are now paid for by some scheme or some insurance. But OPD consults tend to be out of pocket. And therefore, a patient is perhaps looking to skimp on that. Or it could be exactly what you said, which is the turf battle between the referring doctor and the specialist. So I think there are multiple reasons. But as a healthcare community, our objective should not be an either or, but how do we ensure the patient remains under the care of a specialist while having that care being highly accessible, highly affordable. So the entire purpose of perhaps this discussion should be to try and find that happy medium, which can perhaps combine both and not make it a binary choice.
Yeah. So Vivek, let me come to you. you are providing healthcare at home, and that's what your company is named after. When we look at care that we provide at home, it requires a lot of trust between the treating doctor versus what care is being provided at home, and requires a lot of collaboration between the caregiver, care receiver, the hospital, the general physician, etc. How do you, as an institution, collaborate with these other institutions which are involved in providing continual care, just so that the patient not only gets the right care but also the comfort and the confidence that he's in the right hands?
So thank you for inviting me here. I think first of all, what we have also done is we have expanded our portfolio in the out of hospital space, right? So it's not only home, but we have post the hospital, there could be a continuum of care, and hence loss to follow up may happen even before that, right? So so what we have done is we now have physical format centers as well, and then we service patients at home so that we ensure that the patient is taken care of throughout the journey till the time he or she reaches the level of recovery, which is the potential, maximum potential recovery, right? Now, during this process, our fundamental thought process is that the first question which you asked, whose patient? So I think the way we manage is that the super specialist who handled the patient or the procedure he would have done or she would have done, that's the person who's under whose quote unquote supervision is what we are acting upon, right? So the continuum, while we will act on the patient and we'll continue to deliver back reports, reportings, and take feedback from the treating doctor, so that he continuously remains in quote unquote control of the therapy, right? And the systems and processes which we use, which could be technology enabled, or in some cases physically taking back the patient to the hospital and the doctor, is the way we manage the relationship. And while because we continue to take the feedback and act on with the doctor, the relationship continuously remains, and we don't have any super specialist available in our system which will lead to conflict, right? So all the people who we would have are people who would be looking upon to the super specialist, and hence there is no conflict, there is no fear ki mera patient chala jayega, and so on and so forth. That's something which we've been making sure it happens for the last 12 years, and we established ourselves in doing that.
Vivek, how dependent is your business on the remote monitoring devices today?
Well, we have remote monitoring devices which can help, but see, devices alone don't help, right? They can't solve all the problems. First of all, healthcare has health and care both, right? The care component has humans involved. Machines can't care. Right? Care is more emotional in nature, and hence humans have to come into picture. Health, to scale it up, if you can have monitoring devices, it probably addresses the affordability question, the access question कि जहाँ पे कोई नहीं पहुँच सकता है, वहाँ पे the machine could possibly give you the inputs, but acting on the inputs is not the machine's job. Let's say the machine, the remote monitoring thing, gives a beep that something wrong has happened. You will need humans to intervene, and hence it's not, it's part of the story, but a larger part of the healthcare story continues to involve humans, especially on the care side of things.
Let me ask you a question. You are into senior care. Sir, I'll come to you in a minute. You're into senior care.
Yeah.
One of the things that have gone missing from our healthcare system, and at least that's my observation and understanding, is that we have suddenly lost this segment called the family physician or a general physician. अभी आपको चेस्ट में दर्द होता है तो आप अज्यूम कर लेते हो आपको हार्ट अटैक हो रहा है, ठीक है, एंड देन यू माइट गो टू द हॉस्पिटल एंड नो दैट इट वाज अ एसिडिटी प्रॉब्लम, एंड विच इज इट्स अ गुड थिंग, आई एम नॉट सेइंग इट्स नॉट अ गुड थिंग, इट्स अ गुड थिंग दैट पीपल आर कॉन्शियस अबाउट इट. But the fact is, people, without understanding why the symptom is there, based on the symptom that they have, they choose on their own which specialist to go to, right? You are dealing with senior care.
Right.
What is it that you do that overcomes this problem? Do you have situations where the patients tell you कि मेरे को ये हो रहा है, मेरे को यहाँ पे ले जाओ? Or do you use some kind of a system, process, prognosis, some technology to understand what your response should be for a particular problem?
Sure. First of all, thank you so much for having me over here, and very honored to be with this awesome panel here. So just to take a step back to tell what actually KITES does. KITES is not a retirement community. We are not an old age home. We are not an hospice. So what KITES does is we specialize in giving three kinds of care, which is post-hospitalization rehabilitation care, palliative care, and dementia Alzheimer's care at the specialized facilities that we have created and at the homes of the seniors. So that's what we do. So we are out of hospital care continuum partners for the seniors and their families. 50% of the elders who come to us do not have primary physicians, as you rightly said, and that's what we also recognized. And that is one of the things that we try to inculcate in the people who reach out to us. Very, very important that we create awareness for the primary physicians, geriatricians, etc. Quite a lot of dearth in our country, but nevertheless, we have now seen in the last 1 year the geriatricians increasing in numbers right now in India. Though we have 61 MD seats in India, they go unfilled, unfortunately. But I think the younger doctors are also realizing it and taking up these courses, and it's very important that primary physicians takes up this role. Whenever people reach out to us, definitely we give them the right kind of direction. We are not only providers of the care, but also counsel them when they reach out. This is happening and we hear it out. In fact, the first phone call that lands in to our company is to a team of doctors who are trained to understand the need of what they want. Because when people call us, they will say ki ye chahiye. They will always talk the solution. But we hear them out and tell them what the right kind of solution is and accordingly guide them. So as you rightly said, primary physicians and the guidance that is involved, a gatekeeper to the health of the seniors is extremely important, which will enhance. If you know that 70% of the deaths that happen in the US, we don't have data in India, but US hospitals that happen is because of the side effects of the medications. This is where we will be able to, work on seeing that how we can reduce these unnecessary medications, over medications, under medications, interactions, etc., where people are able to play as a gatekeeper to the health of the person and manage the comorbidities, which is in the back end, whether it is neurologists, cardiologists, nephrologists. The seniors will come with 20, 25 tablets. How do we manage all this? So compliance of the medications, how do they go about it? So yes, primary physicians and like geriatricians in the elder age group plays a very, very vital role.
Well, Dr. Kler, first of all, thank you so much for joining us. I know you had a very, very busy schedule. And Dr. Kler, what we were discussing, this panel is about the loss of follow-ups. There's a patient who comes from a tier 2. They come to a large hospital in a metropolitan. They get their treatment, but they head back home, and then they need the care of a local physician there. What are the complications that you think can arise out of it? And whose patient is this?
First of all, no patient is anybody's patient. No doctor can own a patient. That's a fundamentally wrong concept. People will find he's a patient for the last 20, he's my patient, mine. There's nothing called mine. Patients have right to go to any doctor at any time. So we should be very clear doctors in our mind. And on this premise, I realized almost 20 years back that it is totally nonsense to fight with your colleagues. Mera patient, tera patient, mera patient, tera patient. So this is our colleagues are more important to us than those patients. Usually doctors fight, मेरा patient लेगी, मेरा patient लेगी. So please, I will request everybody, all the doctors at least, that patient will come to you or any doctor on his own criteria. You should be confident of your capability, your own confidence in you. कि मैं अच्छा डॉक्टर हूँ. If I think I'm a good doctor, I'm better than the doctor where the patient has gone, I think it is his bad luck. I can't help him. This is my concept. Say, no, sir, patient फलानी जगह चले गया. मैंने कहा मैं क्या करूँ? उसकी bad luck है. Is unfortunate. I don't care. So that's number one. Number two, three things. The when questions are answered, I just overheard when I just entered. The remote controlling devices was the question, and Dr. Vivek was answering those, I think, answers. I think in the future there will be more and more role of these remote control devices in the practice of medicine in the world. And this will be even more important in a country like India, which is huge, far-flung areas. So we'll have to shift to these devices, more and more devices. Actually, one of the segments which is having maximum kind of impetus now, particularly after COVID, as this so-called digital medicine, virtual medicine, far-flung areas medicine. And if you have to make a contact, remain in contact, you have treated the patient. I get a lot of patients from Iraq, from all over the world, Dar es Salaam. So I have treated him, but there's nothing called treatment there's nothing one-time treatment of the patient. It is not that it is appendicitis, I have taken it off and he's no more a patient of appendicitis. Cardiovascular medicine, I'm a cardiologist. Cardiovascular medicine is almost always a continued care till he dies or you die. So that's a problem. So the remote digital medicine can help us. So I tell these Iraqi patients that, okay, you want to take a consultation, virtual consultation after 1 year, take me. Because I know the patient, I don't have to re-examine him, I can give him right advice. Then another question was that a patient, has come from Muzaffarpur, let's say, and I have treated the patient and he was treating by some other doctor. My philosophy is always that until and unless I think that the treating doctor is not up to the mark or he's really bad, then I tell the patient that, okay, I know so-and-so doctor in that area, you might consult him. I don't say change your doctor, diplomatically, that you might talk to the other doctor. Or I tell the patient, okay, let's have, for example, there is a patient, doctor in Karnal, Dr. Gupta, let's say. I know his capability. So if a patient he say, okay, if your doctor, treating doctor, you are not having problem, you can contact him and he will always talk to me if he is in problem. There are doctors in my practice, Chandigarh, anywhere. If they feel that there is a problem with the patient, they will call me. So that's a continued care. And I have students. Now one of them is even chief of interventional cardiology in a peripheral medical, cardiology unit. He still once in 6 months or once in 4 months he'll call me during the procedure. Sir, ऐसा हो रहा है, अब मैं क्या करूं? Because he has a confidence in me, I am available to him. Patient care improves. So it's a very important thing actually that the patient is not being treated by one doctor. That concept is gone. We are not hakims. कि पल्स देखी, सब कुछ इलाज कर दिया, निगाह भी ठीक कर दी, कान भी ठीक कर दिए, पेट भी ठीक कर दिया. It's not possible. We are talking about allopathic medicine. In allopathic medicine, multiple doctors have to see the same patient. The patient comes to me, this is a negative point of modern medicine. A patient comes to me, he doesn't have only heart, he has kidneys, he has liver, and he has his brain, he has got emotions. So we have to have a system, a comprehensive coordination between these doctors. If I refer my patient to nephrologist, I call him कि भाई इसकी क्या प्रॉब्लम है, एज ए कार्डियोलॉजिस्ट मेरे को क्या करना चाहिए, एंजियोग्राफी करनी चाहिए, रुकना चाहिए. So you have to talk to each other. There's another problem, by the way, how patients are mismanaged. Patient or big hospital, I'm talking because I'm always worked in tertiary care hospital, Scots or Max or Fortis. These are so-called big hospitals, multiple specialties, multiple doctors. A patient is admitted, okay, he has some kidney problem, nephrology consultation. Now this guy comes, and he is so focused on kidney, he doesn't see the patient. He doesn't see what is the cardiac problem the patient has come. He will write all the investigation. Like for example, in for all urea creatinine is rising. A patient I have admitted has heart failure. A patient with heart failure will give diuretic so that his urine increases and his water is out of the body, he feels better. So he will say, it's not my problem, it's a cardiology problem, give him more fluids. And that is how the patients are, in a very bad language, how they are fucked up in a modern system. It's a bad language, I know that, but that's the reality. So what my dictum is, that the doctor who admits the patient, he is the primary doctor. No advice of any other doctor should be followed without consulting that doctor. For example, my patient, I have a very clear instruction to my junior doctors, whosoever comes, let him see the patient, let him write whatever he writes. I have to see what he has written. Whatever I tell, do it, otherwise don't do it. So those are the kind of problems we are facing. But nothing, for a patient, there is nothing better than coordination between the all treating doctors. Now, one thing more which I want to answer, because you were talking about primary physician to this Reema lady. Reema, am I right? It's a pity that we, as a country, we have one of the most modern medical doctors, most modern hospital. We have one of the most third-class doctors, third-class opportunities. If you go to just 100 kilometers off Delhi, the primary health center, if you use, you will start, I would like to commit suicide if I see those. I have seen those. I went to Jaisalmer for a trip, and I went to see the civil hospital. Believe me, I won't even take my dog there for the treatment. So, in India, there is no structured development of healthcare. There is no policy. For example, even educated man in Delhi, who is IAS officer, he gets a pain in the upper part tummy, he doesn't know what to do. He calls Dr. Kler, or he has a pain in the back, or he has a sciatica, he calls Dr. Kler. Dr. Kler may be in US that time. Sir, मेरे को टांग में pain हो रही है. Why? Because we have not created a system primary physician. In fact, I tell you, this is absolutely indicated. We have to come to a system where there should be primary physician for a particular number of people in that area. There are, in Delhi, the doctor-patient ratio is much better than the WHO recommendations. If you go to Odisha or Bihar, the ratio is dismal. Why? Because there is a collection of these. There are so many physicians in Delhi. There are, I don't know how many physicians are there in Delhi. So I think if it should be ruled that this physician is the primary physician, he goes to the patient, goes to him, he can handle 90% of the problem, 90 at least. For 10% he knows where this patient is to be referred. For example, Orni Institute and PGI Chandigarh, I am from PGI Chandigarh, is a mess. Why? Anybody can go there. Patient, only referred patients should be gone to these places. So these are so many issues which we need to handle.
I think you've brought this up very well, sir. So, let me come to you, Sidharth. One of the things that is emerging out of the conversation that Dr. Kler was, what he brought it up, is that, when we are looking at a human body, it is not just one organ that we are, looking at. And when we are creating technology, especially remote monitoring, and which is based on just data, are we not taking into account the need for a holistic feedback on what is happening inside the body, which requires a physical checkup? One is that. Second is, how do you, I know you have a product called Life, how do you address this problem of creating a primary physician as well as the consulting physician who's going to be there?
Sure. I think I'll take both of those. So just a very quick summary about what we do. My company's name is Lupin Digital Health. It's a subsidiary of Lupin Pharma, which many of us may know. Lupin Digital Health is a digital therapeutic startup. We work primarily in remote cardiac rehab. So patients who've undergone angioplasties or who undergone a heart failure index admission, we take care of them post-discharge and we drive their healthcare outcomes. We use a combination of remote monitoring, we drive compliance to protocol, and we have several healthcare providers like nutritionists and cardiotherapists, paramedics, etc., who sort of drive overall care. Like Dr. Kler rightly mentioned, I think there is no pure cardiac patient, right? Almost 45% of our patients, we have more than 5,000 patients now on the platform over the last 6 months. More than 40% of them also have type 2 diabetes. Almost 15% of them have some form of renal issue, right? So it's actually a cardiometabolic renal continuum on which you have most patients. And this is not even to mention many of the edge cases where patients may also have psychosomatic issues, etc. But for us, a renal issue, a metabolic issue is extremely common. I think there are three ways for us to deal with it. Like Dr. Kler rightly mentioned, you start with the treatment protocol that has been recommended by the treating doctor. Whether it's the cardio, whether it's the nephro, or whether it's the endocrinologist, your job should be to drive compliance to that protocol and not question why something has been prescribed, right? If we have a doubt, we may reach out to the doctor in question, but chances are he would have evaluated the patient, right? So I think when you are looking at outcomes post-discharge, like Vivek also mentioned, the idea is to drive compliance to the protocol that's been set and not second guess. So I think that's point number one. The second point is the advantage of a system like ours is that unlike a cardiologist or a super specialist who's very busy, we spend a lot of time with patients. So on average, we have specialists speaking to the patient for at least 3 hours a month. And therefore, a lot of these smaller issues come up, right? So we have an ML algorithm that runs both structured and unstructured data. Conversations are unstructured data. And we try and surface some of these issues. And if these are symptoms that the patient is sort of talking about, right? When I lie down, I start becoming coughing or I get breathless. Those are actually telltale signs of heart failure, which he may not, be aware of. So we then are able to record that as a symptom and provide him a report which he can take next time to the doctor. Right? So then the doctor is made aware that these symptoms are actually happening. But in the normal course of conversation, in that 10 minutes in front of Dr. Kler, he may not have mentioned. But in the 1 month that we've been speaking to him, he's been repeatedly giving us indications that he's suffering through heart failure. Again, it's not my job to tell him that you have heart failure, but it's my job to recommend to him that you should see your cardiologist about this particular challenge. So I think that is the second fundamental issue. I think the third point that Vivek also rightly mentioned is that you have to connect both the healthcare aspect as well as the people aspect. So you have to have a multidisciplinary team. They have to be experts in what they do. So I would never have someone of Dr. Kler's expertise in my team, but my cardiotherapist knows his job really well. He knows how to do segmental breathing. He knows how to improve the VO2 max of the patient. He knows how to make sure that the patient is able to cover more distance in a 6-minute walk test. Right? My nutritionist really understands what kind of food a Punjabi person eats, and if I have to make small changes, how can I drive portion control? How can I drive better outcomes without making a 180-degree change? So I think supporting the specialty units with these sort of decentralized multidisciplinary teams, I think would perhaps help. The reason we do it remotely is because we want to make it more accessible and more affordable. If I were to do the same thing in person, every session would cost as much as what we are charging for an entire year.
I think I just want to add what Sidharth said. When we talk about compliance, it's a very, very important issue in medicine. People in India are kind of very funny. I don't know why. They can decide to increase the dose, decrease or stop the medicine themselves. So I tell you, I don't have to go far off. My dad had a hypertension. He was used to live in Punjab, so he came to Delhi. So I started medication. So call him after 2 months that how are you doing? He said, I'm fine. So are you taking medicine? Then he band karti. Why? He said, I thought it may become habit for him. This is the father of a cardiologist. You can think about other people. So we have very funny, because I tell you why. In India, they think any medicine is bad, fundamentally. They may be right in a way, but a medicine which is required is required. So I tell people, you take food 3 times a day. Why you take food? Because you want to live and you have a quality of life. You take protein, you take vitamins, because you want to live first of all, then you have a good quality of life. If a drug is giving you longevity and quality of life, what's the problem in that? But when I say this, the only way to increase, there are 2-3 methods to increase compliance. First of all, doctor has to give time to the patient, fundamentally. He has to explain. 98% of the doctors don't tell a patient of hypertension, Bhaiya, this is a lifelong disease, you have to be on medicine for the life of your life, or you need at least monitoring for the whole life. अगर आपका BP ठीक भी हो गया, 6 महीने भी ठीक है, then monitoring cannot be stopped, because after 6 months BP will start rising again. The doctors don't talk. Now when we come about doctors are busy, I agree they are busy, but then that is not an excuse not to explain to the patient. That's my point. Second thing, we need to have specialty trained nurses in every specialty. And we need to have physician assistants, Like I am very busy in my own, I have to do so many things. But then I see the patient, then that nurse should sit with the patient, explain everything. What Sidharth was talking about, that when you lie down, you start coughing, you have to, if you get up and get relief, that means it's a left ventricular failure. It's a serious symptom. For an ordinary patient, it's थोड़ी खांसी होती है. The patient will come, sir, मेरे को कोई ज़्यादा problem नहीं है, पर मैं जब रात को लेटता हूँ, मेरे बीच में खांसी शुरू होती है, मैं बैठ जाता हूँ, मैं ठीक हो जाता हूँ. And I said, no, भैया, this is not a खास problem नहीं है, it's a very, very serious problem. You go, do the echo of that man, 20% ejection fraction, and his BNP is 13,000, because they don't understand these things. So we need to have a trained nurses, trained assistant physicians, so that we can relegate that training part, how much salt he should take, what activity he should do. Now there is a clear data available that the hospitals in the whole world who have specialized heart failure clinics, their patients do better. Their readmission rates are less. Their quality of life is better. Their longevity is also better. Why? A nurse will call the patient every 1 week or so. Mr. So-and-so, how you are doing? खांसी तो नहीं है, पैरों पे सूजन तो नहीं है, आपका वेट तो नहीं बढ़ गया. It's a reinforcement. So this is the only way to improve compliance, to improve the outcomes of the patients.
If it's okay, I'll add one more to the point that you were talking about. Definitely, it's reiterating again that how primary physicians are extremely important in managing long-term chronic health. And as Sir rightly said, that it is 90% of the people who require tertiary hospital help. And I think it coincides with the data and the research that we have also done, that 20% requires to go to the hospital. The rest can be managed outside. One more thing, and Sidharth is also here. Digital health is the way forward, and especially when it is also coupled with the primary physicians. It has to become a weapon in the hands of the primary physicians to manage the care long term, because chronic means long term, and we have to keep them out of the hospital as long as possible and give the time and the bandwidth to the super specialists to deal with serious cases, which are 10%, and the 90% to be outside the hospital, managed with technology. So at Kite Senior Care, we manage this thing in 4 different stages. One, post-discharge, definitely they can opt to come to our centers for rehabilitation, 2 to 8 weeks. Then when they go back home with the home care help. So again, the follow-ups are there. We have also launched a technology platform where, there is online consultation with our physicians, counselors, dietitians, physiotherapists, etc. What kind of help do you want remotely? And in geriatrics, especially when they are older, it's very difficult for us to pull them out of their homes and their comfort zones. So it is basically required to reach them rather than they reaching us. So at different facets, we have tried to see that wherever they want this kind of help, in whichever form we are there, and we get their data so that we are able to respond in that particular way and able to take care of them long term with quality care.
You know,
More in the healthcare, I think in future you will see more and more role of artificial intelligence. Now there are, for example, in radiology, there's already a lot of established data. See, you can't have expert radiologist available in small towns. So you have to just feed that X-ray to that, AI equipment or the application. It will give you diagnosis. And these AI-based diagnoses are only generated after almost like millions of X-rays being scanned. It's not one thing. I mean, there will be applications in the future that you take a picture of the patient, and that picture, the AI can interrogate and tell that whether he has got heart failure or not. So, lot is coming in the future. I think the most important thing where the medicine will improve, the practice will improve, is the digitization, it's the technology which is going to help the patient again and again. Now coming back to, I'll take just 1 minute more, the holistic medicine. I don't know what is holistic medicine. I have not understood so far this word being used left and right from everybody. What I understand why holistic medicine is, I would rather like to use a doctor, nurse, technician dealing with patient should be passionate. He should have sympathy. He should be empathy with the patient. So till if we don't have the empathy, if we don't have that sympathy with the patient who is a suffering human person, I really don't think what is holistic medicine. Everything else is useless. So that component should always remain. Technology, somebody pointed out that ultimately it's the patient wants to see my face. Even if technology tells that, okay, increase your Lasix to 10 milligram, but he still wants to see my face. Doctor, aap kya kehte ho? So ultimately that human content, human exposure with the interaction with the patient, with the empathy is going to change the medicine.
sir, I'll take this conversation further from the word that you're using, empathy. The problem in India, when you compare the doctors in India versus what we see in the West, is that doctors in India are overworked. They have no time. I mean, we have seen your schedule as well. But when the technology is bringing all this data to the doctor and also, taking to the point where red flags are there, does the doctor have time to respond to this?
Like we have implantable intracardiac devices like pacemaker and ICD, the defibrillator. Now there are many complex heart failure devices, CRT devices, and almost all the companies have a remote data you can have. So in that also there are publications that the remote controlling algorithms in devices, they improve the quality and quantity of life of these patients. There are data available, you know that. But in India, that's a big challenge. One is that the center, or let's say, if I have to see all those patients, I don't have time to see that. So unless we have sufficient number of trained people to look at that data, again it is a challenge. Second thing in India particularly is that patients don't want to pay for this. They will send WhatsApp message, for example. Very treatment kiya hai. I mean, we all do free service. Still, we get gali from the public here. I think, to my mind, Indian doctors are one of the best, most easily available, cheapest doctors in the whole world. But still, हमें लोग गाली निकालते हैं कि जी डॉक्टर सुनते नहीं, खा जाते हैं, लूटते हैं, मारते हैं. I mean, if you go to those parties anywhere in South Delhi, medicine the connect between public and medicine is gone in the wrong way, some or the other in India. And believe me, I have worked in India, I worked in the Middle East, I worked in UK, I worked in United States. Indian doctors are the best in the world. Believe me, there is a data, there is a publication from Harvard. They followed patients, 50,000 patients over a 10-year period in that area. And they were trying to correlate that whether the outcome of patients depends on the physician or it's just the so-called evidence-based medicine. You know, evidence-based medicine means that it's recommended. There are guidelines to do things. Everybody will do the same guideline, then same outcome should be there. And the result of that trial was that the patients treated by foreign medical graduates had better quality and quantity of life. And out of those foreign medical graduates, 79.8% were Indians. So we should be proud of that thing, but in India, you don't have value.
Yeah. Vivek, let me come to you. You want to say something?
Yeah, so I think your question on, see, the doctors here are busy because of the sheer volume we have in the country, right? So whatever we do, the number of super specialists in any specialty, if you pick up, is 5,000 at best. Isko kitna bhi badha lenge, the volume which we have will not be able to reach that level, and that's probably the reason people like us exist in the out of hospital space, to lower the load of the doctors for rudimentary things, right? So even if there are these devices which come up with certain certain alarms or etc., there may be standard protocols which the doctors would have recommended ki ye aayega to ye kar sakte hain, and we execute that and then go to the doctors when there is ambiguity, when there is when there are different conditions which are not there in the standard protocol. And that's where multidisciplinary teams which happen in the out of hospital space, whether in center, whether at home, and managing the patient, would be able to solve this problem. Otherwise, this problem cannot be solved by increasing the number of doctors, right? Because that's a very long process to get a DM. Aaj se 15 saal, right? Just the starting point itself. So for solving the problems, a lot of care has to come out of the hospitals, so that the hospitals and the super specialists treat precisely those points where they are the experts in treating, baki sab bahar.
My last question, because I have loads of questions which I had noted down, but this screen is blaring at me saying time's up. What I really want to know is that specifically, there's a huge connect between out of hospital care and hospitals. At the end of the day, we want the patient to remain well, right? What are the challenges that we face as doctors when we are transitioning a patient from a hospital to out of hospital care? And how do you think technology is solving or can solve this dilemma of the doctor, whether the patient is going to follow up on the treatment? Like you said, log apne aap hi medicine band kar dete hain, and the follow up that is required from time to time. So anyone who wants to share their perspective.
I think the most important thing, maybe slightly cliched, but the most important thing is that the patient should take charge of his own health. I think very often we see patients where the mindset is that I have outsourced my care to the doctor, so it is your headache to make sure that I am well, right? And especially as the burden of the system moves towards non-communicable, towards metabolic and vascular diseases, it is every day counts, right? The decisions you make every single day in terms of what you eat, how much you exercise, how much yoga you do, what kind of stress, how much you sleep, that adds up over time. And once you get the illness, unfortunately, it is progressive and it is lifelong. So I think the most important thing is for patients to take charge. And if they've had an illness now, or if they've had an event and it's been a wake-up call, they have to start complying with the protocol, not just medicines, but also lifestyle modification, which is extremely important.
I think you asked this question from a doctor's point of view. The most important thing the doctor wants is trust, right? That मैंने तो अपना काम कर दिया, but अगर आगे लोगों ने अपना काम ठीक से नहीं किया, there's a very high chance that the patient will come back, for rehospitalization. The case may become, even worse in such cases. So the most important thing is if we can provide those trust to the doctors, right? That yes, we'll take care by showing outcomes, by publishing outcomes, by data, and by these devices which will help, collect and connect the information and showcase that this is the right data information, this is the outcomes which we have created, and so on. That will give the trust on the doctors, which will again reflect back on us, because the doctor will say कि हाँ हाँ यहाँ पे मैंने 100 patients किए हुए हैं, and let's say यहाँ पे rehospitalization नहीं होता है, या they managed well, the recovery is much better, and that becomes a circular story. And once the patient also trusts कि हाँ doctor साहब ने बोला है, then they also hear on whatever advices which we'll give, which will lead to better outcomes for everyone, right?
Yeah. It's very important in our experience also. What we have seen is one of the very important factor is making them part of the decision making journey. That yes, this has happened to me, and that can only happen when the medical professionals are able to explain it to them that this is what you have to do, and this is why you have to do, and this is how you have to do it. Unfortunately, they go back to super specialists who are dearth of time. Again, makes it more important for people like us to be outside who are into chronic care to explain it to them why, what, and how, so that they take their own decisions along with their family, and then take the ownership of the decisions and do it by themselves. It's very, very important, and we have seen it being successful because they have taken the decision, though we have prompted that from the back end. It's not a front door entry but a back door entry, but it seemed to have worked.
I think the crux is that it's a two-way street. So when you look at the doctors, we want them to get a feeling of serving the society. And at the same time, I think what is emerging is that the patients need to take ownership of understanding that they're seeking help rather than saying कि मैं पैसे दे रहा हूँ तो मुझे आप ये outcome दो. It's not a transactional thing. At least the business of healthcare should not be treated as transactional. But I think the technology is playing a very, very big game in terms of at least having the information flow happening so that both parties, the patient as well as the doctor, knows what is going on, and if there is a corrective action that can be taken well in time, I think we'll be having a population that would lead a healthier and longer life. With that, I would like to, sorry.
Just one I only. I think it has been a very fascinating session, to be honest. I think in India the problem is fundamentally Indians don't want to spend on their health. It is something in their mind. They don't mind buying jewelry, making big houses, throwing parties. But when it comes to health, itna महंगा, it is in mind. It's a mindset. So I think we need to teach our public, sensitize our public that, in fact, I have started telling wherever I go, I give them talk that health is most important thing in life. So you must invest in health. You must invest in health, and this investment is of two types. One is that you should learn basic health principles. That means we need to give health education to people. Second thing I see, the day you start earning money, 10% इधर रख दो health के लिए. Keep 10% on this side for my health. Insurance कराओ, जैसे कुछ भी कराओ. So it's not free. Like these guys, they are doing a good job because doctors are busy, so they are taking the onus of, like heart failure patients, some other patients like rehabilitation. But patients, they don't want to pay them. They have a problem. मैं तो ये पहले वहाँ खर्च के आ गया मैक्स में, अब आप फिर मांग रहे हो. So there is nothing free in this world. These people, they have everybody who wants to create like Lupin, for example. This is a very good initiative by these guys, but patients have to understand they have to pay. It's nothing free. That's a problem. We have to train our minds in India that health means you have to spend money.
Thank you so much, Dr. Kler.